we talked a bit about your career, but I'm interested in knowing the key decision point for you when you decided to become an anaesthetist. Like, why an anaesthetist? Why not anything else?
Yeah, I guess I had enjoyed everything pretty much in medicine. So all the terms I did as a medical student, I didn't want to be a cardiothoracic surgeon. I kind of had made the decisions about some of those heavyweight sort of specialties, but I didn't really know what I wanted to do. And I hadn't ruled out GP. Often in med school, I think general practice is given a terrible kind of rep, but
it's always what specialty do you want to do?
Yeah,
and
people don't
people
perceive
fall back on.
It's a sort of a failure specialty, but the perception is 60% or more of medical students will become general practitioners. And actually, if I had my time again, don't tell anyone. If I had my time again, I'd have been a GP.
Wow.
Because you get set up quickly. You're in control of your own destiny. The stuff that interests me as much as the medicine does is all the non-clinical part of this job, which there's ample scope to do in general practice.
Example?
So education is a good example, but managing people, managing processes, quality improvement projects, quality improvement work, leadership and management, all those non-clinical parts of becoming a senior clinician, there's ample scope for those. And you're in control of your own destiny, right? You can choose the hours you work and the places you go. And as a dad of 3, the non-medical time becomes as or more important than the time you spend at work. And all the mates that are now general practitioners are all very happy with their lives and pleased that they either fell into it, were pushed into it, or chose to do general practice. However, I did ED in Perth and loved it. And I think if I'd have stayed in Perth, and 5 of my mates stayed after we all left, and most of them became ED physicians, I think if I'd stayed, I would have done emergency medicine. It was great over in Perth. But I came back to an intensive care job, just a standalone, I guess, SRMO equivalent job. And the people that covered the on-calls overnight were anaesthetic registrars. And they were all...
On-call for what? Just
for the unit. So the senior cover.
Right, for an ICU. Okay.
Yeah, it was uncoupled at that point. So there wasn't an intensive care specialty.
Specialist.
No.
Yeah, okay.
So mostly it was anaesthetists who subspecialised in intensive care, who then ran the units as consultants. Okay. And any which way of doctor could staff the middle kind of tier. But they were mostly the senior support in the hospital after hours were anaesthetic registrars. And they were all, nice people who loved their job and were happy and were good doctors. And I was like, I want to be like that.
Yes.
And so I decided to try my hand at getting an anaesthetic rotation and fell into one.
And it's one thing to see and admire doctors and kind of want to emulate them and go on their path. But then when you start the job, it can be a bit different. Did you start anaesthetics and just be like, this is what I want to do, even when you were junior? Or was it something that over time you liked more and more and it was confirmed that that's what you wanted to do? Like, was it an instant kind of hit, or was it something that needed some time?
I definitely felt instantly comfortable in the decision that I'd made, but uncomfortable in knowing nothing about the specialty that I'd chosen. Yeah. It's, again, different to here where as an SRMO, you'll get exposed to the critical care specialties.
But it's a very, at least at St. George, it's a very competitive SRMO year, isn't it?
Yeah.
Hopefully I think there's some other hospitals are also doing critical care SRMO.
Yeah, I don't know much about the junior system over here, but certainly in the UK, you go from having never been in theatre to being an anaesthetic registrar day one, having no experience. So you go back to feeling like a medical student where you don't know very much about the processes or the way that people do stuff and the medicine behind it. The learning curve with anaesthetics is pretty steep in a good way. So you get pretty proficient at giving a standard anaesthetic to a simple, to for a simple procedure to an uncomplicated patient pretty quickly. You don't actually have to know very much to do that. It's all practical. But what you realize when you take the exams is that there are some good reasons why you do things and some bad reasons and things you shouldn't do. And so you backfill the experience stuff with some knowledge, and your world just opens up to the eclectic mix of recipes and drugs that you can use to help or hinder patients along their journey.
And all the kind of, like you're saying, you get really proficient at the standardized safe patient, no comorbidities, normal use case, but then all the exceptional use cases is where the bosses come in. I guess I'm interested for you why you didn't choose ED or ICU, because I'm interested in critical care, and I don't know which way really. I've only done an ED term. I didn't get ICU this year, so I'm going to try and do some ICU and anaesthetics later on. Luckily, I got a peds term though, so that's good. But yeah, how did you make the decision for yourself personally, and what advice do you have to other junior doctors like me who want to kind of make a decision between the three? And is it just trial and error? Do you just have to try it all and see what clicks?
It seems like it's a dirty word or dirty process these days. You're not allowed to meander around different specialties and try on a few different coats and see if they fit. And I think that's a real shame. They made a decision in the UK, they being the sort of, the powers that that drive policy or structures around recruitment and subspecialization, that if you had done orthopedic surgery as a junior doctor for 5 years and then ended up being a general practitioner, you had wasted your time. That was the decision that was made. And it would have been much smarter for that person to have been funneled into general practice earlier. The downside of that is that all that knowledge based around trauma and soft tissue and hard tissue damage that they take to general practice, where you need different people who can
Different niches, right?
have different niches into skin and bone and a women's health or whatever it might be. I don't see that as a waste of their time. I just see that as improving their skill set in a niche part of what we all need to be able to do as a collective, for example, in a general practice. So, me wandering around doing a bit of ED, and I did about a third ICU during my anaesthetic training. So again, back in the UK in the sort of early 2000s, you do a lot of intensive care, and I loved it. And again, thought heavily about being an intensivist. The downside, and a thing I keep coming back to as I sort of talk to people about their career decisions, is you'll love everything you do as a junior doctor because it's all the fun stuff. You've got to work out whether the job that you will be trained to do is the job you want. So look at a consultant intensivist or a consultant anaesthetist or indeed a consultant ED physician and say, that's the kind of job that I want at the end, because they're not the same as the job that you do as a junior doctor in those specialties.
And you have to be comfortable with the boring or the unsexy side of the specialty.
Right.
Like ED bosses, they get the good stuff, but they get a lot of the bed block, logistics, staffing. I mean, it's an ED consultant that does the roster.
Yeah.
That's mind-boggling to me, because that's hours of work that it's thousands of dollars a fortnight that of healthcare expenditure that could be better spent.
So that's the other part to the decision making, I think, is that look at the specialty you think you want to do. Look at the worst thing about that job. If you can put up with that worst thing, that specialty is for you.
So what's the worst thing?
Because the fun stuff is the fun stuff.
Yeah. Everyone loves the fun stuff. But what's the worst thing about being an anaesthetist?
So I guess it's that, sitting in a theatre, watching a machine, bing-bonging at you while you have your colleagues ferreting around in an abdomen for 5 hours. If you can put up with that, because the fun stuff of getting that patient safely asleep and getting them safely emerged and dealing with their pain relief, those portions of the anaesthetic which are small, they're the fun stuff.
Yeah.
And it's the same for, radiology. Feeding little wires into people's brains and putting coils up there is fun. Sounds fun.
It's crazy, yeah.
And a bit crazy. But sitting in front of a computer screen and reporting on
100 chest x-rays.
CTs or chest x-rays in a dark room for 90% of your day, if you can put up with that, you should be a radiologist.
So Laurence,
Hey, if you want more highlight clips of the Doctors Getting Coffee podcast, then don't forget to hit the subscribe button down below and make sure you hit the bell icon next to it to get notifications whenever there's a new highlight clip. I'm releasing sometimes 4 or even 5 clips per week, then make sure you hit that button. Now, if you want to watch the entire video podcast, consider becoming a Patreon or a YouTube member to support the channel, and you will get, as one of your special privileges, access to the entire video podcast library. I'll see you in the next video. Bye for now.